welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
I'll introduce our first presenter is Leslie Banuelos. She's a PGY2 emergency medicine resident at the University of Maryland Medical Center. Today, she will be presenting fixed dose ketamine for pre-hospital management of hyperactive delirium with severe agitation. You can go ahead and share your screen, Leslie. Thanks for being with us today.
Thank you so much for that introduction, and thank you for having me. So as for my presentation, my mentors and I have no conflicts of interest to disclose. However, this presentation will discuss the off-label use of ketamine for hyperactive delirium with severe agitation. So before discussing this study, I'll be going into some background information. So first, we'll go into what exactly is hyperactive delirium with severe agitation, or HDSA. So it's an acute life-threatening medical condition that needs emergency medical treatment. It's a syndrome of delirium that has altered mental status as well as psychomotor agitation in a hyperadrenergic state. The syndrome of delirium with severe agitation has been previously described in the literature as agitated delirium or excited delirium syndrome. Although these terms are no longer used, it is now termed as hyperactive delirium with severe agitation. So some of the features most associated with hyperactive delirium in a pre-hospital setting are having constant physical activity with a lack of tiring that sometimes is referred to as having superhuman strength, having increased or abnormal pain tolerance, tachypnea, diaphoresis, and tactile hyperthermia. And additionally, some laboratory abnormalities may include hyperkalemia, acidosis, rhabdomyolysis, and acute kidney injury. The pathophysiology for hyperactive delirium with severe agitation is not fully understood, but it seems to be multifactorial that's resulting from many factors that contribute to this abnormal state of brain function. There may be underlying factors such as having psychiatric illness, psychiatric medication withdrawal, and lastly, stimulant abuse. Additionally, there's been recent literature that suggests that there could be a high level of endogenous catecholamines that when in combination with inflammation and oxidative stress can lead to this hypodopaminergic, hyperadrenergic state that leads to this agitation, delirium, and violent behavior that is seen. As for the complications of hyperactive delirium with severe agitation, so as we've discussed, it's a severe life-threatening condition, and patients that present with hyperactive delirium with severe agitation are at risk of not only direct physical trauma, but also additional injuries from having restraints. Patients can develop hyperthermia, which can lead to multiple organ injuries or multiple organ failure. And their increased metabolic drive can also lead to rhabdomyolysis. And lastly, the combination of these vital abnormalities, the metabolic derangements, and agitation can ultimately lead to mortality in these patients. So the American College of Emergency Physicians Task Force on Hyperactive Delirium with severe agitation in emergency settings put out a report in 2021 on the recognition, evaluation, and management of patients presenting with hyperactive delirium with severe agitation in the pre-hospital setting and in the emergency department setting. They state that patients that present with hyperactive delirium with severe agitation should be initially provided verbal and nonverbal de-escalation. If the degree of agitation does not improve, or if there is concern for safety, then escalation to pharmacological options is necessary. Additionally, there is no consensus on what an optimal medication or the best medication would be, but intramuscular ketamine, droperidol, olanzapine, and midazolam are the options that are best supported by the current literature at this time. So now we'll discuss ketamine. So ketamine is an N-methyl D-aspartate or NMDA receptor antagonist that does induce a dissociative state of anesthesia and analgesia. The use of ketamine for hyperactive delirium with severe agitation is considered to be off-label, so there is no actual FDA-approved dosing for this. but the current literature does state that a dose of 3 to 5 milligrams per kilogram intramuscularly would be an appropriate dose. A benefit of ketamine's use is that it has a relatively quick onset of action within 3 to 5 minutes when given intramuscularly when compared to other pharmacological options. However, there are some safety concerns with the use of ketamine with its side effect profile that includes increased blood pressure, which could lead to complications in patients that already have elevated endogenous catecholamines, and ketamine-induced hypersalivation and laryngospasm, which may compromise a patient's airway and respiratory status and lead to intubation. So now I'll be discussing some of the previous literature on pre-hospital ketamine. So the first study that I'll be discussing is by Kroll and colleagues. So this was a single-center prospective observational study of patients with severe, acute, undifferentiated agitation that presented to an EMS system and transferred patients to a level 1 trauma center. The study assessed whether haloperidol or ketamine is superior for the treatment of severe pre-hospital acute undifferentiated agitation. And this was determined as an altered mental status scale or AMSS score of +2 or +3, meaning that they were defined as being anxious or agitated or very anxious, agitated with a mild physical element of violence in 146 patients over a 1-year period. For the first 3 months of this study, the standard operating procedure was to treat with 5 milligrams per kilogram of intramuscular ketamine, and this dose calculation was made by EMT paramedic estimated weight in the field. And then for the final 3 months of the study, the standard operating procedure was changed back to haloperidol 10 milligrams IM. All patients with severe acute undifferentiated agitation that were transported to the hospital were included in the study, but patients were excluded if they were pregnant, appeared to be less than 18 years of age, or had profound agitation that was determined by an AMSS score of +4, which was defined as being very combative, violent, or out of control. The median dose of ketamine that was given was 5.2 milligrams per kilogram intramuscularly, and the median dose of haloperidol was the 10 milligrams IM of haloperidol. This study did find that ketamine had a quicker median time to adequate sedation, which was defined as an AMSS score of +1 of 5 minutes in the ketamine group compared to 17 minutes in the haloperidol group. Additionally, ketamine had a higher likelihood of adequate sedation achieved, but there was a higher rate of complications with ketamine compared to haloperidol, which included hypersalivation, emergence reactions, and laryngospasm. So the next study that I'll be discussing is also by Kroll and colleagues. So the previous trial by them, the patients that had profound agitation, which was determined by this AMSS score of +4, defined as being combative, very violent, or out of control, were treated and the data was collected. However, they were excluded from that study. So this study by Kroll and colleagues assessed the effectiveness of ketamine 5 milligrams per kilogram intramuscularly for that profound agitation with that AMSS score of +4 in the pre-hospital environment in 49 patients. The median dose of ketamine in this trial was 4.9 milligrams per kilogram. That was based on weights obtained in the emergency department. And they based the dose on pre-hospital calculations based on weight estimate. The median time to adequate sedation was 4.2 minutes in the ketamine group, and sedation was achieved in about 90% of these patients. 7 patients did require additional sedative medications in the pre-hospital setting, with 1 person receiving 10 milligrams of intramuscular midazolam, and 6 received additional ketamine ranging from 100 milligrams to 500 milligrams. Hypersalivation did occur in 9 patients. 4 of these patients did receive atropine for hypersalivation, 2 which were intubated. No patients suffered laryngospasm in this trial. However, there was a high rate of intubation at 57% of the patients. There were no pre-hospital intubations. All were done in the emergency department, and the most common reasons for intubation were due to having an unprotected airway, hypersalivation, respiratory failure, or hemodynamic instability, to which the authors determined that some of these intubations may not have been necessary. So in conclusion, in this study, it did show that pre-hospital ketamine administered at a 5 milligram per kilogram IM dose did provide rapid sedation to profoundly agitated patients. And although there was a higher rate of intubation, this may be due to variances in physician practices. And the last background study that I'll be discussing is by Solano and colleagues. The two previous studies did show benefit of using pre-hospital ketamine in terms of quick onset and adequate sedation, but they also highlighted a higher rate of intubation. This study aimed to evaluate whether patients treated with pre-hospital ketamine with concomitant substance intoxication had higher rates of intubation in the ED compared to those without confirmed substance usage, as it's known that many patients that may present with hyperactive delirium with severe agitation oftentimes have illicit substance ingestion. This was a retrospective chart review of patients that were treated at 2 community hospitals and included patients 18 years or older that had intramuscular ketamine administration by pre-hospital providers for hyperactive delirium. They were treated with 400 milligrams of IM ketamine, and it could be repeated once as needed. And if the patient was waking up, they were able to give midazolam 2.5 milligrams intravenously or by intraosseous infusion, or midazolam 5 milligrams intranasally or intramuscularly. This study did find that patients that were treated with intramuscular ketamine with hyperactive delirium and had cocaine intoxication had a 5.75-fold increase in the rate of intubation in the emergency department, and there were no other trends identified with any other substances. So this brings us to our study, which is fixed dose ketamine for pre-hospital management of hyperactive delirium with severe agitation. So this study is a single hospital multi-agency retrospective chart review from January of 2019 to December 2021 that aimed to determine the safety of a pre-hospital fixed dose protocol of 250 milligrams of intramuscular ketamine for hyperactive delirium with severe agitation by evaluating frequency of adverse events based on a New York State Department of Health EMS protocol. Cases were included if the patient was 18 years or older and received 250 milligrams of intramuscular ketamine from a standing order. The protocol did allow for a second dose of ketamine if adequate sedation was not achieved. And patients that received ketamine for any other reason were transferred between hospitals or received ketamine by direct oversight from a physician were excluded. For our baseline characteristics, 60 patients met the inclusion criteria. The median age of our patient population was 34.5 years, and they were a majority male. The median weight in this group was 80 kilograms, and the initial weight-based dose of the initial 250 milligrams of ketamine, it was recorded based on the patient's weight that was recorded in the hospital. There was less than 3 milligrams per kilogram for about 42% of the patients, and 58% of the patients received a 3 to 5 milligram per kilogram dose, which is consistent with the dose that's recommended by literature. No patient received greater than a 5 milligram per kilogram dose. 12 patients did receive a second 250 milligram fixed dose of ketamine for a total of 500 milligrams. And of these 12 patients that received additional ketamine, there were 5 patients that received a total ketamine cumulative dose of greater than 5 milligrams per kilogram, with the highest recorded being 7.3 milligrams per kilogram. Additionally, 4 patients did require benzodiazepines prior to the second dose of ketamine. However, none of the patients that received either a second dose of ketamine or benzodiazepines had an adverse drug event or were intubated. Now, this table shows the 7 patients that had pre-hospital and hospital adverse events following the 250 milligram fixed dose of ketamine in the pre-hospital setting. No patients were intubated by EMS in the pre-hospital setting. 3 patients did receive support with a bag valve mask from EMS and were ultimately intubated. 1 patient, described by line 4, did get suctioned by EMS but was not further intubated. And in total, 6 patients, so about 10% of the patient population, were intubated in the ED, including the 3 that received bag valve mask support from EMS and 3 that received additional sedation in the emergency department. A logistic regression model did evaluate the effects of the initial weight-based dose on the risk of intubation and the total cumulative dose of ketamine on the risk of intubation, and also found no statistically significant association. So the author conclusion of the study is that the initial dose of ketamine was effective for about 80% of the patients. 4 patients did have pre-hospital adverse events related to the administration of ketamine, and further research is needed to determine what the optimal dose of ketamine for hyperactive delirium and severe agitation is, and if employing a standardized fixed dose streamlines administration and reduces dosage errors. So for the literature evaluation, some of the strengths were that the study really tried to attempt to simplify ketamine protocols and avoid dosing errors, especially during a time when weight estimation may be difficult in the field. So having a fixed dose of ketamine limited the variability and complexities of dosing ketamine in the pre-hospital setting. Overall, it was a very safe protocol for the management of hyperactive delirium with severe agitation in the pre-hospital setting, and the patient population is pretty representative of what the disease state is. While it did show benefits, it does have some limitations. First, it's a retrospective chart review of a statewide protocol that was conducted at one hospital with a small sample size of 60 patients. Additionally, the weight that was used to calculate the weight-based dosing was the weight that was obtained in the emergency department, and it's unclear if that estimated weight was observed or it's the actual body weight of the patient. And lastly, the patients were either able to receive ketamine or midazolam by this EMS protocol, but there were no clinical signs or symptoms available that informed what the paramedics used to make that decision. So as for my conclusion, the study did show that a pre-hospital fixed dose of 250 milligrams of intramuscular ketamine was adequate sedation for about 80% of the patients. Additionally, after adjusting for weight, all patients received less than 5 milligrams per kilogram of intramuscular ketamine for the initial dose, which aligns with the 3 to 5 milligrams per kilogram described in literature. And there was no correlation with initial and total weight-based dose with risk of intubation, even with those that received up to 7.5 milligrams per kilogram. And additionally, there was a lower risk of intubation at 10% compared to previous studies, although some of these intubations may be due to variances in provider practices as well as administration of additional sedatives. So to summarize, the pre-hospital 250 milligrams fixed dose of IM ketamine does demonstrate the benefit of having a safe, protocolized method of treating hyperactive delirium with severe agitation with ketamine in order to mitigate dosing errors. Most patients achieved adequate sedation. The dose may not be sufficient for all, and patients will require close monitoring in the pre-hospital and emergency department setting due to the adverse effects of ketamine. I'd like to thank my mentors for all of their help with my presentation. Here are my references, and I'll be open to taking any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.